document that. Oh, thanks. But I love Joanne. In any case, that was the tenor in that June, and it wasn't clear that Ebola had invaded the city. Although, when I went to visit Marta in the hospital, as she was standing up with her colleagues there, an Ebola isolation unit, which obviously the city was going to be needing desperately. I remember one of the first things I saw, I was there with Dee, and she said to me in Haitian Creole, she pointed to two funeral announcements for two nurses, youngish looking. We didn't talk about that, and said, begin till not, it's already there. And there was no reason to believe that it wasn't there, because there weren't people looking for it in any kind of systematic way, and there was no Ebola treatment unit at all in western Sierra Leone, where the capital is, only 200 miles to the east in Kenema, where the staff was about to die, the nursing staff and the medical director, who some of you may have known, who was to spend his sabbatical year here, 2014, 2015. That background, I think, is important because Marta and her colleagues, the ones I met with, 3 very young nurses and 2 British fellows, and Marta. And Marta was taking the lead, but didn't want to take the lead. They knew they were in peril. And, you know, it takes a special kind of courage, because there's no craziness involved here. Not at all. It takes a real kind of courage, not only to stay and brace yourself for what was absolutely inevitable, that it was already surging west towards the city, but also to look out for so many others on the staff of that hospital, and then many other facilities across western Sierra Leone where the epidemic was rapidly concentrated in the months after June, and was reaching a peak we thought in August, and then again in September, and then no, it had not peaked. It would not peak until months later. I saw Marta a half dozen times during those months or more, and one thing that really pleased me was to be able to reintroduce her to some of the people whose lives she and her team and her precautions had saved. Because they would talk about this white angel, that was what one person said. Another knew it was a Spanish angel, who had always had, in the middle of this horror show, which I hope she'll talk about, always had a chance to be kind and affectionate at a time where, of course, she was completely covered from head to toe. And it was much commented on by the patients that we saw, and she's become good friends with many of them since then. So when you say, you know, and you can close your ears, you know, when I say she does the professions proud, I mean clinical professions, nursing, medicine, etc. She's a great ID doctor. She has a flair for leadership, which she didn't wish to discover, but had to. But she is also a fantastic colleague, is a committed teacher and researcher and clinician, and I hope we are lucky enough to formalize her links with this department, because she is a real hero of academic medicine, Dr. Marta Lado.
Wow.
And I didn't cry.
No. I am the one who's going to cry now. Well, thank you, everyone. I know that you all must be very busy and taking the time to come and to learn a little bit more about what is going on all over the world, and take the place that we should be having, no, in our society as doctors and as people who are worried for social justice, and also for the for the situations that are going on in countries like Sierra Leone that I'm living, but also Congo, etc. And just forget about only your environment and crossing that line and going to see what is going on out there, I think is something remarkable. So thank you very much. I know that all of you are committed to global health, so it's going to be a very easy talk in terms of we are going to be able to talk in the same perspective. No? One of the things that when we were talking, because I was coming to Boston, they were asking me if there's anything that I could talk about that I could feel comfortable with. I don't know why this is not working. So I don't want to spend much time in introducing myself, because I think that Paul has already said many things, even more than what I expected. Thank you very much. But to give you like a little bit of context of why this woman is coming here to talk about Congo and what happens with Ebola, etc., is you know that I'm based in Sierra Leone. I belong to the PIH family, and I had the privilege with the PIH family to get the opportunity of taking some time off in October, November, because there was like a real need in the Democratic Republic of Congo because of an outbreak that had started in July 2018. They had an outbreak of Ebola in the east of the country, in Ecuador, in January, that they were able to contain very well. And it was not the first time that Ebola was present in Ecuador. So they put everything in practice, they put all the measures in place, and everything worked really well. So in 2-3 months, the outbreak was finished. And everybody was saying like, oh my God, we learned so much from the West African outbreak. And look how effective have been all the measures. But then in July 2018, new cases started coming in what is the west part of the country, North Kivu. Just to give you an idea about where Democratic Republic of Congo is, it's just like in the center. They had many outbreaks before, like small ones in rural areas, but North Kivu didn't know anything about Ebola before this outbreak. So they asked me from WHO, we are a group of clinicians that we have been working in the clinical guidelines after the West African outbreak. We have been working really extensively, and Paul knows about that because also he has been advocating and participating quite a lot in being able to develop clinical guidelines, intensive care, individualized care for patients that are suffering Ebola. So in West Africa, we're not able to implement many of these things, but we all wanted to make a difference if this happens again. So this is the main idea that is happening in Congo. Congo is a war zone. It's a very complicated war zone because it's not really, there are no two bands. There are probably 5 or 6 different parts of the conflict. You never know who is a rebel, who is a soldier. The soldiers are rebels at night. There are attacks continuously. It's like a very conflicted area. So Ebola is not exactly the perfect situation that could happen in a place like this. Now, if Ebola was already complicated, just put it in a war zone, and then you will find that it's more complicated. But I will get there in a little bit. So just to give you an example, like why is happening this outbreak, these are previous outbreaks that we had from the Syrian, that is a subtype of Ebola that has been having higher rates of mortality. But you see that Congo has been having many of them previously, then also a little bit of Nigeria, but also the West Africa. So it's not new. Ebola is not new in these areas. North Kivu probably, yes, but they have had probably more outbreaks of Ebola than any other area in Africa before. And it's apparently, this Ebola is considered to be like some kind of zoonosis that live in some reservoirs. There are bats. This is quite controversial right now. There are many other theories that are coming on. But it's true that the distribution of these bats corresponds really well with the distribution of previous outbreaks of Ebola, as you could see in the map in brown. So that is what explains more or less why Ebola is affecting these areas. But then we go to DRC. Now, this is the last report that I was able to find from WHO. And since July, we have been having like a small peaks, but right now we are in a quite delicate situation. We have reached 1,000 cases, despite what I'm going to tell you that has improved in DRC. And we will go, I would like to have like some time later just for questions and comments, because it's a very interesting topic to try to understand why, despite all of the things that we know, we are already in 1,000 cases in this area. So the four main pillars of the Ebola response, one of them is based in case management. It's about how do we treat it, how do we treat the cases, how do we get people to come to the healthcare facilities because they trust that they are going to get any kind of treatment. Second is about case finding, surveillance, contact tracing. Just start thinking yourself as I'm talking, like imagine that this is happening in an area where they have attacks every day. Okay, there are bombs and gunshots and all the things every day. So you can imagine that case finding, contact tracing ends up being extremely complicated. Then the third one is the safe and dignified burials. Many of you would ask why burials are so important in Ebola, and it's because Ebola is a viral disease that this virus tends to multiply inside your body, inside of your fluids, and mainly the blood. And as you get more sick, the viral load is higher, and it's one of the few diseases that even when you die, you can infect others. Because when you are dying is when your viral load is so high that you can find it even in the saliva, even in the sweat. So the moment that you are preparing a dead body to be buried or whatever, you are in contact with him. And in certain traditions, in certain areas, the way that you treat your dead bodies is what is allowing them for the next life that they are going to have. So you need to pay your respects to the dead person. So then you wash the body, you treat it, you dress it well, you put it in the coffin or wherever you're going to use to bury him. And that moment of extremely contact is when many people get sick. So that's why burials are so important. Ebola patients, when they die, are the most infectious ones, even more than when they are having the symptoms. So that is a very important pillar. And the fourth one is the social mobilization. We are talking about regions that had never heard Ebola before, that suddenly imagine that something comes here and it's like, there's a new disease that is killing people, and also all the things that you see is that international partners coming, just white people coming around, bringing a lot of money. When we have been in war for almost 20 years, nobody cared about us, and then suddenly all these people just come and, oh, look, Ebola is here. It's like Ebola has killed 2 people today, but the war has killed 15 people today. So this is a very important pillar, and it was in West Africa, but in DRC, and mainly in North Kivu, that didn't have any outbreak before, is one of the most important things. So if we start from the different parts of the pillars, the first one, the case management, for the ones who don't know too much about Ebola, Ebola is a disease that is a big pretender, because in the way that it comes in the beginning can simulate anything. Imagine you have like an incubation period of more or less 1 week when you don't have any symptoms after being in contact with someone with Ebola, and in less than a week, more or less 5 days, 7 days, you start with weakness, with headache, with fever. That could be anything. That could be flu, that could be malaria, that could be typhoid, that could be just simple cold, that could be even stress, and maybe when you are malnourished, you have many different problems. You can feel this kind of inspecific symptoms very easily. So that's what we say, like, it's a big pretender. It could be anything. And this is the big problems that we have about detecting cases of Ebola in the beginning. No? The symptoms are very specific. Is the phase that we call, in Sierra Leone, we call the body de warm. Like your body is warm. No? The body de warm is the first phase. It's how people describe, like, when you ask them, like, do you have fever? It's like, no. The body de warm is like, oh, yeah, the body de warm. So you should learn this kind of things when you are, at least this is in West Africa, in Sierra Leone. The second one is the caca fast, no? Like the diarrhea, no? Like the toilet fast. And it's very typical that after the 7th day, you start presenting symptoms of abdominal pain, like cramps, a little bit of diarrhea, a little bit of vomiting, but it's very specific in the beginning, as I'm saying. Could be anything, no? Just like start thinking about like how would you, if you were in the screening area of one hospital and somebody's coming with these symptoms, would you definitely go to Ebola in the first place? No, you would think that is anything. And this is one of the big problems that we have with Ebola. Like, this is when people start giving you antimalarials, ciprofloxacin, ceftriaxone, ORS, thinking that it's a gastrointestinal disease, no? And it's Ebola already. And then the third one is about what we call the torment, which is like this confusional state, like you are super weak, you cannot walk, you are a little bit disoriented, and many patients end up getting into this neurological complication that is some kind of encephalitis, like very confused, this kind of staring that they are not able to fix their attention on anything, and then they end up, many of them, when they get to this neurological phase, they end up dying. And I will explain later that many of these symptoms in West Africa, we were just describing them. In the DRC outbreak, with all the researchers that we have right now working in Ebola, we have been able to identify many of these things. For example, the torment, many of them has to do with hypoglycemia. We are seeing that 90% that people that come to treatment centers after 1 week of disease at home, they have a very severe hypoglycemia that is not able to be sorted out just with normal fluids. And many of our patients died in West Africa in the first 24 hours, and we didn't know why. They came walking, and then 24 hours they are dead. Now in DRC, we are doing glycemias to everyone when they are admitted, and we are seeing people in maybe 10, 20, 25 milligrams per deciliter of glucose. And even given B5,
hypokalemia.
Hypokalemia is another thing. More hypokalemia than hyperkalemia.
Yeah.
But for example, and I will explain to you all of this later with the lab results. But the glucose is something that for us were shocking, and maybe the ones who were working in West Africa, because we didn't understand many sudden deaths that we had in many patients, and many of them are because of electrolyte disturbances and sugar. So this is a virus that works very similar to malaria, like produces like a consumption of sugar very easily, and also the vomiting, the diarrhea, and the low intake of food make this hypoglycemia very complicated. So as I said before, the different phases are the early phase, which is like very specific. The second phase, that is the gastrointestinal phase, with a lot of diarrhea, vomiting. We're talking about diarrhea that some people get to 10 liters of stools a day. So when people were saying in the West African outbreak, and Paul and I had many conversations about this, about like, just give ORS, it's okay. Like, listen, you can never compensate 10 liters of losses. So you end up having dehydration everywhere, no? Like, many of probably the renal failures that we were seeing is not only the virus itself, it's like a pre-renal, no? Like, even some of them probably, like, they end up doing a tubular necrosis because of this hypovolemic shock, no? And then the terminal phase, which is when you start just being in bed all the time, extreme weakness, and we will talk about that, because there's also a rhabdomyolysis going on in patients. Like, there's a destruction of muscle that you could see in the CKs. Like, the CKs go to 50,000, 60,000, 70,000, and it's one of the reasons why these patients are so weak. Apart from the losses and the dehydration, also there's a destruction of muscle capacity. So, as I said before, the early phase is a very specific one, and it goes all in 1 week. The gastrointestinal phase, it could be a little bit longer, depending on how it's treated, but also the patients are complaining with myalgias, arthralgias, and I will show you later that the CKs are completely crazy. So when we see renal failure in these patients, could be, we are considering three main things. One is dehydration. You are losing a lot of fluids and you are not compensating them. Second, probably could be also the rhabdomyolysis can end up producing renal failure. And the third one is about probably the virus itself produces an interstitial renal disease. So don't be surprised when I will show you later that probably around 85% of the patients that we are seeing in treatment centers, they come with renal failure. So this idea about dialysis, about ultrafiltration, and renal replacement is not such a ridiculous thing that as many people wanted to make us think during the West African outbreak, when they were saying, like, we need to bring dialysis, and everybody, you're crazy. This is West Africa. We don't have an ICU, and now suddenly you want to bring dialysis machines here? But we are seeing many of our patients in DRC that the main problem is a renal problem, which is quite surprising, is that despite this renal problem, this renal failure, there is not so much hyperkalemia. You would expect, like, when somebody's in anuria, that is quite common just to develop this kind of accumulation of potassium. But in these cases, I think it's because of the diarrhea. They lose everything, no? And then we have, like, the terminal recovery phase, which is when the fever and the GI symptoms subside, and then is when you start having the encephalitis and confusion. And also, as I said, like, the renal failure and the multi-organic failure in general. So one of the things that I think is very important as clinicians to understand about Ebola is that Ebola produces shock in many different ways. One is the hypovolemic shock. So then, I think we all know how to treat hypovolemia, no? So then, these contrasts... ORS, this is exactly... That is what it's a ridiculous thing. Like, discussing with someone if we should give IV fluids or not is something just like, it's so ridiculous at this level. Like, Ebola is not that... apart from the effect of the virus itself, it's about, like, all the consequences of the symptoms that you have. So the fluid is something that is not, should not even be discussed. It's just like, give as many fluids as you can. Maybe in children, and mainly children malnourished, you have to be more careful about, like, the weight and giving and everything. But in adults, just go crazy. Give as many fluids as you can. There is no discussion about that. Another one is the septic shock. And this is the part that we need to study more. And probably during this outbreak in DRC, we will be able to get more information about what is exactly the damage that the virus is doing itself, and not only because of the symptoms that it produces. Okay? And then the third one is the hemorrhagic shock. This is the part that everybody gets confused. Ebola tends to be considered as this disease that produces bleeding everywhere. All your holes, like your nose, your mouth, your diarrhea, everything is just completely full of bleeding. But the reality is that we don't see bleeding so much. It's less than 25% of the patients present with any kind of bleeding. So if you're waiting for the bleeding, you're going to miss all the cases of Ebola in the screening area, in the triage, in one hospital when patients are coming. Don't wait for the hemorrhagic stage, because this is the last one. It's when, and also it's quite curious, because what we see is that the prothrombin is okay, the cephalin is okay. It's true that in some cases we see some thrombocytopenia, so probably has more to do with resistance to the function of the platelets, or also like coagulation factors that are dysfunctional, but it's not because they are reduced. And this is one of the things that for me was very shocking. I was expecting, when we were working in West Africa, we didn't have labs, so I could not see what was going on when my patients started bleeding. But in DRC, you see somebody coming with retroragia or melena, and then you go and the prothrombin is completely okay. The cephalin is completely okay. The platelets are okay, or maybe 75,000. And it's like, why is this person bleeding? So there is something that we need to learn still more. But it's true that when people start bleeding, if you combine them later with the thrombocytopenia that could happen because of the cytopenias of a viral infection, definitely gets worse, and people can end up dying because of hemorrhagic shock. And one of the things that in DRC is happening right now, which is making like a huge difference, is the transfusions. Transfusions of whole blood that is bringing like new platelets, new coagulation factors, and people are making it because of this kind of facilities, when in West Africa it was completely impossible to think about doing any kind of transfusion inside of the treatment centers. So in the clinical management, as I was saying before, there are two main things that we have to have in mind about Ebola. One of them is the gastroenteritis. The severe gastroenteritis is something that we definitely need to pay all of our attention, but then also we all know about management of sepsis. And this is the part that has been forgotten for a long time. These patients present with multi-organic failure and with sepsis, and we need to manage them. You would never consider a patient that is coming septic to your emergency department to say like, oh, just give some fluids. Just give him something to drink. Maybe some paracetamol. No, what would you do? You start taking vitals, monitoring, urinary output, everything that is in your hands about like vasoactive drugs like dopamine, noradrenaline, etc. And this is one of the things that we are able to do in DRC, and I will explain to you later, which is the individualized intensive care that we are trying to set up now for Ebola patients. It's true, and some people can argue with me, that now it's easier because we don't have so many cases. We have been in DRC, we have been having like 1 or 2 cases a day in all the country, like in all the regions, so then you can individualize things. In West Africa, there was a moment that we had like maybe 200 cases a day, and it was completely impossible, but we could have done things in the way that we are doing in DRC right now, yeah? Because at a certain point it wasn't the same level in the beginning. So for the ones who want to review a little bit, this is where everything comes from, and it's like a consensus from many of us who were working in the West African outbreak. We got together and we started discussing about like, listen, let's forget about the evidence that happened before. Let's create our new evidence. If you were from the beginning and you have to decide how you're going to treat your patients, what would you do? Would you give antibiotics? What antibiotics would you give? Would you give fluids? What fluids would you give? How would you manage this kind of septic situations or the different shocks that are happening? So this is the guidelines that we are going to be extending now in the presentation about like what are we doing right now in DRC. So first of all, big difference. Now the testing of Ebola is done by GeneXpert. Forget about the real-time PCR. GeneXpert, 90 minutes. The machines are normally like 4 cartridges. So they have like, definitely, it's not only one machine, but we have several of them. But right now there are 8 active laboratories in North Kivu with GeneXpert machines. And they are doing GeneXpert all the time, 24 hours. And it's 90 minutes every test. Apart from that, we are detecting the GP and the NP, like the glycoprotein and the nucleoprotein. This is what makes difference because the glycoprotein is the one that we are given also with the vaccine. So then we can know if this person has been vaccinated or not. So the nucleoprotein is the one that we are definitely using to see if the patient is really sick or not. So we give the result of both of them. But the good thing is that it's something that is super quick. You get one patient, in less than 2-3 hours, you get the result. That has made a big difference for everyone. The second one is the laboratory and point of care devices. This is one laboratory that is just inside of the treatment center. This is like a huge achievement compared to the West African outbreak. No, we are able to do labs in all the patients every day. So we can calculate all the electrolytes. We can see exactly what is going on inside. So normally we are using the Piccolo machine, but iStat has been also available in other areas. And the good thing is that you don't have to have people in PPE all the time. They can be using this kind of high security laboratories that they can just be working from outside, using the gloves just to go inside and manipulate the samples. One of the big criticisms that we had in the West African was about like, how do you expect to do labs? We don't have biosecurity labs. We cannot do laboratory. We cannot do lab tests in our patients. It's so dangerous, like managing Ebola samples all the time. So this is one of the things that has been changed right now. And it's incredible, like taking labs from all the patients every morning. So you come and before you start doing the rounds, you sit down with the nurses and we go through all the determinations. We see exactly how the kidney is, how the electrolytes, how the liver function, etc. So one of the things that we are seeing in the patients, just to give you more or less a little bit of information, is that we normally do full blood count, coagulation, biochemistry, and CRP. And with that, more or less, is how we quantify, and the CK, to quantify the situation of the patients. So what we see normally is, as I said before, renal dysfunction is something that happens in the first week. And it's amazing. That's why we think that it's not only because of the dehydration, it's also because of the virus itself. Because before people start getting diarrhea and vomiting, many of them have already a high urea and creatinine. So there must be some kind of interstitial disease, like parenchymal disease, that is produced by the virus itself. Also, the acidosis, most of the times related to the losses and the gastrointestinal symptoms. A lot of differences between sodium in terms of dehydration, low intake, etc. The potassium is mainly low potassium, but in some cases we have seen like high figures, and then the hypoglycemia. The glucose is something that is constant, and this is one of the things that we all have learned in DRC. Like the moment that you have a new admission, the first thing you do is put a D50 in this patient. That's the first thing. Glucose before anything else. You don't even have to check the glucose. Like 95% of the patients come with severe hypoglycemia when they come to the hospital. So apart from that, Ebola virus is a very funny virus, and I think that I find it fascinating. It's this kind of hepatotropic mononucleosic virus that we are discovering now. All of the patients develop renal damage, liver damage, like the transaminases go up, like probably almost 100%. The amylase is high, and that's why in the West African we were seeing like many patients coming with this epigastric pain and vomiting and oral intolerance, and we are seeing that probably has to do with a pancreatitis that is also produced by. That's why I say like it's this kind of mononucleosic virus, but also the CK is something that is very impressive. Like we don't go to very rhabdomyolysis figures, but at least most of the patients go between 10,000 to 50,000 CK in the labs. So that would explain many of the symptoms that we were seeing in West Africa that we didn't understand exactly, no? So apart from that is leukocytosis, anemia normally, even without bleeding, and thrombocytopenia. Like the platelets also go down. So this is to give you like a little bit of context. This is West African outbreak from 2014 to 16. The left one is the treatment center that happened in Kenya. Now just take a minute and look at that picture and look what is the quality of care that you can give in a place like that. The one on the left. Like that was subhuman. That is like, I remember, I don't want to be controversial, but I remember this when we were getting in a very bad moment in Sierra Leone with Ebola. We were having a lot of cases. It was just exponential, completely crazy. And I remember this meeting with many international partners, big organizations, big donors. And somebody said just publicly, without no shame, like, what we need to do is we need to take the stadium and just put all the patients inside of the stadium and just close the door. And this was said by people who were going to run the response of Ebola in Sierra Leone. So that was the solution that they were given. Because we were discussing how many staff are we going to need. And they would say like, okay, let's put 10, 15 nurses, but the most important thing is that all the patients with Ebola go inside of the stadium and we lock everything. That was the idea. That was the basics in the outbreak of Ebola in West Africa. And this is what during the outbreak we were trying to push and push. And as you could see on the right, this belongs to this Italian organization called Emergency, that they were very criticized at a certain moment, but they were the only ones who decided that they were going to intubate patients with Ebola and doing dialysis on patients with Ebola. You could be agreeing with the Italians or not, but the reality is that what they did was exactly what should have been done from the beginning of the outbreak. And this is the point that we want to get to DRC right now. Individualized intensive care for patients. It's true that when Emergency opened this high technology treatment center, the cases of Ebola were just going down. And it was, but why do we intubate and put in dialysis people when we bring them to Emory Hospital, to Carlos III in Madrid, or to France or UK, but when they are in Sierra Leone, we don't do it? So Emergency opened a door there for many of us to feel confident about like, okay, let's try to fight for something better for our patients with Ebola. So then this is, I'm going to give you some examples. This is the treatment center that ALIMA is a French NGO that is working mainly in West Africa. ALIMA is set up in DRC, in Beni, which is where most of the cases were. I am a huge fan of the cubes. These are what we call the cubes. And this is like a completely new story about Ebola. I get super excited with this, because these are all these, you could see like every cube is individualized per patient. So the patient is inside here. You can be here around seeing all the patients from outside, like I am right now. You don't need to be wearing any special protective equipment. You don't have to be like an astronaut. You can be completely normal. So then you are outside, you can see all the patients, and then the staff comes at the back of the treatment center. They come from the back door, and then they see the patients, but also they can be taking the vitals. So I can be recording the vitals from outside. So I can work it. But I will tell you more. You see these small holes that are here? These are small holes that you can put an oxygen concentrator here and pass the nasal cannula around here so then the patient can have oxygen. And you don't lose the machine of oxygen because it's not in contact with the patient with the body itself. Perfusion pumps. Monitors. We tend to monitorize patients with the ECG, the saturation, the heart rate, etc. But the coolest thing was the Bluetooth ECG. That was just like the coolest thing that you could ever see. Like you just put the patches there, and then with my iPad outside, I just do, and I do the ECG in a patient that is having a severe hypokalemia, and I really want to see how the T's are. So these are things that are possible. And in West African outbreak was completely unthinkable. At that time, you remember that we were even discussing if we should put cannulas or not, and now we are doing ECG through Bluetooth, which is amazing. We also started doing CPAPs, like non-invasive ventilations, and I think that the next one, when I was there in October, November, we were trying to figure out the thing about like the ultrafiltration. Maybe not proper dialysis, but at least a filtration that could allow the patients that are anuric to recover their diuresis.
Is this difference possible because the baseline medical infrastructure was better, or because people know how to bring stuff in more effectively?
No, and this is one of the big controversies that we have there about like, we are doing intensive care in Ebola patients, but what happens with intensive care in other conditions that are not Ebola? DRC, right now, the healthcare system is extremely weak also, and the services that are offered to patients in the hospitals are very, very weak.
So this is all imported technology for
This is only for Ebola. And this is where we can get later into discussion, no? Like, we all agree that we need to give the best for our patients, but we are only doing it for Ebola. What happens with the rest of the things, no? The rest of the conditions that we see in the country. So what we do is, well, you can see this is my friend Shevin. That's myself. So you can see the cubes, no? You can be outside here, you can be talking to the patients, but also has made like a big difference in terms of you can have an obstetrician that can be advising. You can have like an infectious disease doctor that can be advising. We have an ICU doctor that is outside and is guiding and mentoring all the people who are inside about like, do this, do the other thing, try to do that, and making decisions, etc. So we can have high qualified specialists that could be approaching all the patients at the same time, which is impressive. No? So as I was saying, we have all the technology right now in place to be able to do it with all this protection that we needed to do with the healthcare workers, that protect yourself to be able to treat the others, etc. But at the same time, the patients can have high standards of care. But one of the coolest things, and also has helped quite a lot, is about the family can come and see the patients and see exactly what is going on. They go, they sit down, they can talk with them. So as I was saying, like these are also, you can pass things from inside to outside according to through the back, the holes to pass the different things. But for example, if in a moment you need to fix a couple of things and you don't have time to get changed and go inside, you can always use the holes and just trying to fix the IV line, etc. And just trying to give encouragement to the patients. They don't feel abandoned. They don't feel isolated anymore. They know exactly what is going on. They see people treating them around all the time. So this is ALIMA, which is one of the biggest examples that has created like a new innovation in the management of Ebola. No? The MSF Butembo, and I will go through more comments later, but MSF had 2 treatment centers, Butembo and Katwa, and also Mangina, sorry, 3. This is while Butembo was still going. It was not exactly like the cubes that we had in ALIMA, but they opened the idea of being able to show what is going on, so the patients could see outside, we could see, so the relatives of the patients could come and could be here and could be seeing the patients inside. The patients, if they are able to move, they can come outside and talk to their relatives, which is like a huge difference, no? And also, we have been working very closely with ALIMA, but also with MSF in terms of trying to standardize the same standards of care in all the treatment centers. Like making sure that everybody gets labs, that everybody gets the vitals taken every 2-3 hours, that you are quantifying the urinary output, that you are seeing how is the saturation, the perfusion, etc. So apart from these new structures of infrastructure and logistics, now we are in the next stage, which is, are there any new therapy? So are we really assuming that Ebola is just like about managing symptoms of dehydration, of hypovolemia, of hemorrhage, or septic shock? So there were many different things that were tried in the West African outbreak, many different drugs, and different components, like, for example, convalescent plasma, which is plasma from survivors that could be given to another person who is in an acute phase. The reality is that none of them gave like a very positive result. So none of them were superior to placebo, to doing nothing. What we really confirm is that the intensive care, the supportive care, the fluids, and the rest of the complications about electrolytes, etc., is what is saving the patients. It's not so much the drugs. But now, and this is the role that I was doing when I was in DRC, there is like a new program that WHO is very committed with the Ministry of Health and INRB, which is like the Institute of National Research in DRC, in Congo, which is one project called MEMORY. It's about like monitor emergency use of drugs that are not registered. It's compassionate use, and it's about 4 drugs that apparently have gone through different processes in terms of phase of trials and research that are trying to be implemented and used. So the group that I belong to from the clinical experts of Ebola, our responsibility was going to DRC, and every time that we diagnose one patient with Ebola, we go to the treatment center and we make sure that this patient is monitored every 2-3 hours, is given all the fluids and all the intensive care that it needs, and also one of the experimental drugs is given. So when I was there in October, November, we didn't have a randomized clinical trial. So it was more about like, we all sit down and we decide which one we want to give, depending on the capacity of the treatment center, like how much do you have to monitor this drug when you are giving it, and the conditions of the patient. No? So for example, as I was saying, like the algorithm was very easy. Like, does the patient have confirmed Ebola? Yes. Consult with the clinical expert group that normally were one of us, one of the clinicians from the treatment center, and the people from the National Institute of Research of Congo. And then if the treatment center has adequate capacity, we mean like, do you have nurses enough to take the vitals of this patient regularly? Do you have staff enough to be monitoring exactly how is the infusion? Do you have like laboratories to check how the different organs are responding to the drug that you are administering? Then if you have good capacity, you can offer the patient any of the 4. And normally the reality is that we were like quite subjective, no? We were quite biased. We have our favorites because we see that some of them were working more than others. We saw a couple of them out of these 4. It's just like you have one patient with 1 million copies of virus in blood, and after 6 hours you repeat the viral load and you go to 1,000. And which is like impressive, incredible. Not all of them, but at least 2 of them. So we tended to be like a little bit biased about which one we prefer to give because we saw like better effects. So that's why the randomized clinical trial was so important.
No one from the New England Journal is here. You can tell us.
I think that I signed something with WHO about like not talking of the results until they are published. But the reality, and then when limited capacity, we used to give more remdesivir, max-pancatose, or Regeneron because they tend to be more like one dose, and the infusion time is shorter. The problem with CMAP is that CMAP produces a lot of side effects in terms of rash, in terms of anaphylaxis and everything, so you have to be monitoring the vitals every 15 minutes. So you can imagine like being inside of the unit with your PPE and everything for 3-4 hours, taking vitals every 15 minutes is something that not all the treatment centers were capacitated to do it. So, but the rest of the drugs were really very easy to be administered. But, so it's 3 monoclonal antibodies and 1 antiviral. So these are the 4 drugs that we are using right now in Congo. No? Oh, sorry, we cannot see this. Ah, okay. I think that I want to. So yeah, so we have the CMAP, as I was saying before, is one of the most complicated ones because it's like the infusion. You have to give 3 doses separated 2-3 days between them, and every dose has to go for 4 or 5 hours, and you have to monitor the vitals every 15 minutes. So that implies that you need to have like a very good amount of staff, and you can only administer during the day because during the night sometimes you are dealing with problems with electricity or this and that, and it's more complicated. So remdesivir is one of our favorites. It's an antiviral. It's the one that we were using more for people who were having like pregnant women because apparently, and this is all in theory because there was no evidence about that, we assume that the antiviral penetrates better the placenta compared to the monoclonal antibodies, etc. So we used to give it more in pregnant women, but also it's very easy to administer. It's just like 1-2 hours. The only problem is that normally we give for 10 days. So then it implies that even if the patient has got better, you keep him for 10 days. You see the difference, like in our West African, it was just about like people were 2 weeks, 3 weeks, and they were lucky if they were able to survive, and now it's like, shall we give remdesivir? Because maybe in 2 days he's okay and can go home. So maybe remdesivir is not a good option for this one because it's not very sick. And we don't want this patient to be here for 10 days. That is the big difference, the big change of mentality that we all have now, no? Another thing with remdesivir is that apparently should not be given in people who have very severe renal failure, which is something that, I'm sorry, if this patient is going to die, I'm going to give him something. And this is the main purpose of these 4 experimental drugs that we are using in DRC. No? The most important thing is all the intensive care that we are giving. It's not so much the drug itself. So if somebody is going to die, I'm sorry, I don't mind if it's a child, if it's a newborn, if it's a pregnant woman, I'm going to do whatever it takes and try to see. So that's why we don't have any kind of limitation about indications of therapies right now in DRC. Then the mafsankatox, this is a drug that has been produced in Congo from some previous survivors. What do we?
You type your password.
Ah, sorry. The mafsankatox. So the mafsankatox became like the favorite one. First of all, and I'm going to be controversial here.
Congolese, right?
Yeah, they're going to be, it's Congolese. So every time that we were discussing about like, oh, I would give remdesivir to this one, the people from the Institute of National Research was like, no, mafsankatox has to be the one that we give. And it's like, well, but we are not seeing so many, it's working really well, but it's not one of the favorites that we all have, no? But it's Congolese, so has been favored quite a lot, and it's true that it's going quite well, and it's super convenient to give. It's just like one infusion, it's 1 hour, and it's done.
It's like you liking Rioja wine.
Yes, like, give me one Rioja and just take the Sauvignon, no, I won't mind. And then the Regeneron is the last one. The Regeneron probably is our favorite. It's a cocktail also of several monoclonal antibodies, and normally goes like 2-4 hours, and it's like some kind of miracle thing that you infuse it, and it goes really well, no side effects, and the viral load goes super down very, very quickly. So many of you would ask about, like, what happens in pregnant women? So we all know that the problem that we have with pregnant women during Ebola is that Ebola tends to produce miscarriages. Like, normally most of the pregnancies don't go further until term. It's very easy that the woman ends up losing the baby because of probably coagulation problems, etc. So, and you can imagine that also it's very complicated to manage this kind of miscarriages and even labors, because there are a lot of fluids, there's a lot of blood around, and those are the most dangerous, high-risk things that we have with Ebola patients. You don't want to be in contact with too much blood, with too many fluids, no? So pregnancy has always been this kind of unknown area for Ebola. Before this outbreak, we didn't have evidence. Before the West African outbreak, we didn't have any evidence of any women who was able to get to term with the pregnancy and deliver a healthy baby and the baby surviving. In the West African outbreak, I think that there are like 2 or 3 cases published. Probably we had more, but they were not very reported. But the thing is that we were not very ready to do deliveries in treatment centers. We didn't have the structure, and also it's always this kind of fear with pregnant women. No? We were always assuming that the baby was going to die. In Congo, the interesting thing is that we have realized from the beginning that pregnant women were always left aside in all the clinical trials, and all the new therapeutics, all the new experimental drugs, always pregnant women and newborns or little babies, you always put them aside because it's dangerous for them. But the reality is that it's more dangerous that you die of Ebola. So we started giving all these drugs, all these protocols that I'm explaining to you is including pregnant women and children of all ages. And apart from that is creating protocols about how to make deliveries, how to make even C-sections, instrumental deliveries, like using forceps and everything. And those cubes that I was showing you that I find so cool is one of the most amazing things, like being able to have like an obstetrician that could be directing from outside just the delivery, and having one midwife and one of the nurses inside just doing. I've witnessed myself C-sections, forceps deliveries, vaginal normal deliveries. It's true that many women lost the babies because the disease itself produces like a problem in the coagulation, and then the placenta and the rest of the fluids of the baby end up getting affected, and also like a low growing of the babies, etc. But many of the patients, and I will show you now some figures, many of the patients definitely were able to deliver babies, and babies that also recovered from Ebola. They were born with Ebola, they were able to be recovered with the medications and the fluids and all the different things that we're doing, and went home afterwards, being healthy. So this is like a completely new, different story. Okay, so as you can imagine, the big challenges from pregnancy and Ebola is the bleedings, the amount of fluids, and also the long periods of time that the women is doing the contractions and the work of labor, and you have to be in PPE inside, just monitoring her and making sure that she's doing okay. So one of the things that we are more worried, and could be another lecture to talk about, is about like, okay, what are the real dangers of pregnancy in Ebola? One is pregnant women with Ebola itself, which is the first small doll that you have up there. There's one woman who is pregnant, she gets Ebola, and then we assume that her and the baby, both of them are having Ebola right now. Imagine that is a pregnant woman. She gets Ebola, but she's able to be lucky to survive, and she goes home. This baby that she has inside, we need to consider that this baby has Ebola, because Ebola tends to get into the placenta and the amniotic fluid. So this woman, and this is one of the big complications that we have with all these survivors that are pregnant, is just like you send them home, but you need to organize with them to come back to the treatment center to deliver. They should not deliver at home, because you don't know how much of the virus is in the baby. So you need to do like a safe delivery. And then what we don't know is...
Can I just ask, at what point would that even be in the first term, the first trimester? You'd still... Yeah. And of course you'd recommend they come back to their... I mean, if they're infected early, if they're no longer viremic in the first trimester,
we
It's
consider
still
that the baby
a reservoir.
Yeah. So one of the big questions is about like, okay, my husband, my brother, my sister got infected. I didn't get infected, but I had like a close contact with them. I'm pregnant. Is that baby, I am dangerous? Is my baby dangerous? Can I deliver at home? Can I deliver in any normal facility without protection? This is one of the big questions that we have right now.
So are you doing a serological test after they may have
They
been exposed to see if they...
No, and I will explain later. Like the problem with the contacts in Congo is that they don't have a good contact tracing system. So we are not able to track many people. You can imagine that in a place where there is war, and when many of the soldiers of the army are rebels also at night, so you don't know who is the good and who is the bad anymore. Most of the people don't want to be tracked. So when you go doing surveillance to see the contacts, people lie about their names and lie about their addresses, and they disappear. Like if you have found one case here, and then you make a list of all the people who are living with this person, tomorrow you go back, and none of them are there. Because they think that that could be also a way that the government can be tracking them. So then they don't trust the system, apart from the second part of the story, which is like, you go, you track all the contacts of this patient, and then tonight the rebels come and start attacking this village, and everybody runs away. And you don't know where they are, which is one of the biggest problems. So the contact is a pending thing. It's true, there is like a very strong program about pregnant women who survive Ebola, and they go home, and later they make them come back, and also they have like some kind of birth waiting homes, at least inside ALIMA, like some kind of a special tent that the pregnant women can be in the last weeks of the pregnancy before they deliver, just to make sure that they deliver inside of the ETC. So the only data that I was able to find published that I could disclose with you was, I can tell you that it's more, but published that we officially can talk about it, is in February, 12 pregnant women had delivered while admitted in a treatment center in Congo. 7 of them had survived the delivery and Ebola, and 3 of these newborns were discharged completely healthy, home, being safe for them and for the community, which is like a huge difference with the West African, when everybody was saying, this is not possible, we can never get this.
Not only that, there were some NGOs that were going in that were aborting
Oh, yes.
in West Africa because they said 0 had survived, and when the clinicians fought back, maybe they haven't survived because you're not giving adequate treatment, they still continue.
So I remember exactly, and I think probably one of the same case that you're saying. I remember one case that we were talking, and it's just like, it was like a statement. It was not even a decision for the woman. It's like, before you leave the treatment center, we're going to do an abortion on you. And the woman didn't really understand exactly what was going on. It was a decision that was made just mainly by the clinicians in the treatment center. No, like you could see that there was no clear consent of the woman. The woman didn't really understand. What they were saying is that whatever you have inside there is super dangerous for you, your community, everything, so we have to remove it before you go. And
More than once, yeah.
so another super incredible innovation is the vaccine. You know, like there is a Ebola vaccine that has been developed during the end of the outbreak in West Africa, mainly between Guinea and Sierra Leone. It had like very high rates of effectivity. Apparently, we are still checking how long the immunity is going to last for. So right now, in the studies that are going on in Sierra Leone, the people who were vaccinated, they are still having immunity, but we don't know if it's going to be a lifelong, if it's going to be a 5 years, a 10 years, so we are still just waiting and seeing. But in Congo, they have been giving the vaccine to all the contacts of people who got Ebola, all the healthcare workers, and anyone who wants to get vaccinated. So right now, so far, they have vaccinated around 92,000 people in Congo right now. And I can tell you, like in advance, that it doesn't protect 100%, because we still have people who come that said that they were vaccinated at home. But many of the people vaccinated also presented less symptomatic than the ones who were not vaccinated. So definitely it's protecting.
Did you get it?
No, I was not able to get this
I
right.
tried to, yeah.
This next time, yes. So that moment, the problem is that when I arrived, I was going to be only 6 weeks, and after the vaccine, you can have like 1 week that you are a little bit sick. So then I decided to wait and not do it. But with all the national staff are all vaccinated, and also they have started vaccination in Uganda and Rwanda, just to prepare for potential cases that come. But the amazing thing is that it's true that the cases that we have of people who are vaccinated, because normally it's one of the things that we ask the people, like, were you vaccinated before coming? And everything, is that also many people probably had been vaccinated after being in contact with someone that they identified. But maybe there were other people who were also infected in that house before. So maybe they have been exposed to them before, and when they were vaccinated, they were already in the incubation period. So that's why you are not protecting. So we will have to analyze the results of the vaccination. It's called vaccination in a ring, because it's just like you have one infected, which is the black one, and then the red one is the contacts that live with them that are vaccinated.
So since in the first study in Guinea and Sierra Leone, no one who got the vaccine immediately got Ebola.
No, there were two groups, no? Do you remember? Like one was
3 weeks and one.
And
so
the
what do you
ones,
think's going on here? It's the same vaccine, right?
Yeah, it's the same vaccine, but I think
Worse,
that
worse control, worse contact tracing.
the contact tracing is worse, yeah.
Yeah.
And also, you mean like what is going on in terms of people getting infected?
Is it significantly less than 100%? Or?
Yeah, probably
That one,
around 87.
NIH
That's what they
people
were
had
saying.
lots of critiques of that first study because they didn't get all the rings. People turned it down and people left. So they missed a lot of people. So the ones that they did get, they were able to show it, but there was bias that was introduced because they didn't do it as they had planned in the protocol. And so even I think Cliff wrote something to say that you can't call this 100% because you missed much stuff.
Yeah, no, but also now the population is bigger, definitely. It's not that one. And as I was saying, like many of at least when you start talking to the patients, what they tell you is that they got vaccinated probably after the third member of the family got infected, because that's when the surveillance team came to their village. Yeah. But they had been already exposed to 2 previous ones. So you don't know really when they were vaccinated, they were already in the incubation period. But it's true that most of the people vaccinated are pauci-symptomatic.
That's great.
They come with less symptoms, and they survive more.
I'm getting it. You better get me some.
Then we have as you remember the pillars that I was explaining to you. So then the safe burials is something that has been very, very difficult to approach, mainly because it's like it goes into the identities of certain communities, and also it goes beyond the disease itself. Like people die all the time in the region because of the conflict, because of the basic diseases, the stupid deaths that we have all the time about malaria, typhoid, and everything. And it's like, and now you tell me that I cannot pay my respects to my relative, and I have just to give you the body, and you are going to just put the body wherever you want in a cemetery that probably is not where the family is. We are not going to be close to the relative. You're not going to allow me to. How are we going to make sure that this person goes to heaven in the situation that he should be if he's not dressed in this way, he's not presented in a specific way, no? So it has been complicated, and mainly here in Congo, the problem is about, like, there are so many deaths for so many things, and the armed conflict, that people reporting deaths is something that is very complicated to manage, like the logistics. That's what I mean. The community sensitization. This is one of the big problems. Like Congo had several outbreaks before, as I was explaining to you, but North Kivu was the first time. Normally, most of the outbreaks had happened in the east of the country. So this is the first, in the west of the country. So this is the first time that happens in the east. So there's still a lot of mistrust. There was an article in Lancet, like I think it was less than 1 week ago, that after some surveillance, like some research and survey in the community, they were saying that 25% of the community didn't believe that Ebola was real. And we are talking about like already 1,000 cases of people affected since July 2018. So we still have a long way to go.
Sounds like the United States.
Yeah, right. So And then we go to the third part of the problem, which is, well, this up there is Katwa Treatment Center from MSF. This is Butembo, so it's not very well. And that one was the response to one attack in ALIMA. You see the cubes, no? So they in ALIMA Treatment Center. So February 2019, we don't know if it's the community, if it's the rebels, if it's like the army or whoever it is, but they burned 2 of the treatment centers of MSF with people inside, healthcare workers, Ebola patients who escaped during the fire and everything. And then we got to the situation that, well, you could see like what I was showing you before from from Butembo. This is also Butembo. So MSF has pulled out
Completely?
the 2 treatment centers that they were running, which is the 2 hotspots, Katwa and Butembo, which means that right now it's only ALIMA and WHO that are working on the response. There are no other NGO who wants to work in doing Ebola work.
The CDC is 1,000 miles away.
Sorry?
The CDC too.
Yeah.
They're not there.
So
Wow.
right now, in March, again, the treatment center was burned, the Butembo one. So the situation that we have right now is that the Ministry of Health wants to keep the treatment centers that MSF had set up and they were managing, because we have the staff, like all the nurses, porters, doctors, etc., are Congolese, so they are still there. So the Ministry of Health has taken it and has partnered with WHO and UNICEF to try to run it. But there are no other partners apart from ALIMA willing to come to Congo to work in Ebola. Despite all these amazing things that I was telling you, how things have changed, how exciting it is, the war and the conflict and the attacks and everything is making everything extremely, extremely challenging. So they reopened after burning Butembo, as I was showing you. You see, like this is Butembo also. So they just started shooting inside. Like as soon as the Ministry of Health fixed it, opened it again, they started just like gun shooting the other day, like 2-3 weeks ago. So yeah. So this is the situation that makes the Ebola outbreak in DRC more complicated. We are in 1,000 cases, and it doesn't look like it's going to go down right now. But also, as we were talking yesterday, everybody's saying, no, you cannot do it because there is a war. What happens if we say, yes, let's try to find a way of doing it? So if I can bring this idea into your minds and this idea about, like, we should be able to find a way and not just, like, get comfortable with that statement that, no, it's not possible because there is a conflict zone or whatever. And this is the criticism that we do for partners about, like, we need more people to come, we need more people to get engaged. It's 1,000 cases. If we don't do anything, in less than 3-4 months, we're going to go to, like, the West African outbreak or even worse. So thank you very much. This is the road that takes to Beni, from Beni to Butembo. It's 2 hours driving in a non-paved road, which is great. The only problem is that there are some people attacking the road all the time, so it's not very easy to move around. But Congo is one of the most amazing, beautiful countries that I've ever seen in my life. It's just like this kind of incredible bush, super green, a lot of animals, everything grows there. It's incredible. And that is why it's probably so valuable, and the war is still ongoing because people want to keep on taking resources from them, the mining, etc. Yes?
So the cubes are amazing. But when you have this individualized care, do you have any estimate for what the case fatality rate is?
Yeah, we were having 36% of mortality intra-ETC compared to 70% from the West African outbreaks. So 36 was the last time that we are calculating it every week. because we do reports. But yeah, the last one is 36.
How do you manage the temperature in those cubes?
To be honest, if you notice, the cubes have some kind of ventilation, which is amazing. You see this thing, no? Like,
Yeah.
so it's not really, I am not going to call them AC because it's not really AC. But these machines are the ones that are in charge of cleaning the air all the time. And it's quite fresh, to be honest. Compared to what we lived in West Africa, oh my God, you could be hours inside there, no problem. Yeah, I know. And you are better inside the cubes that are outside.
Did they get the cooling jackets yet for under the PPE?
No.
No?
No, I did that in West Africa and I thought it was terrible.
Yeah.
Like, you know, like, in West Africa there was a moment, I don't know who was the donor. Somebody came one day, sorry?
Oh, well, Bill Gates was.
So they came with
that,
these
yeah.
vests full of pockets. And the idea is that in all these pockets, you put like this kind of ice bags. Sorry, I'm Spanish, so I'm a little bit inappropriate sometimes. So don't take me in a wrong way. But it was terrible. It's like my breasts were completely frozen. Like I wore it once below my PPE, and my tits were completely like ice cubes. I was like, I cannot use this anymore. I'm sorry. I don't know. Maybe it works for other people. For me, it doesn't work. And also, after 2 hours, they become like boiling hot bags of water. So then you go from being completely frozen to completely burning. So no. I didn't like them. Did you try it? Do you remember?
Yeah, but I only got to try it. I never got to use it in practice.
That's because we used to spend like 2-3 hours inside, like with no limit. So in the beginning, you spend the first hour like because they are frozen. They come from the freezer, and then afterwards they become super hot. So it was. But yeah, no.
Can you talk a little bit about how these units got developed and who developed them? And it sounds like they were ready to go at the beginning of the epidemic. So.
Yeah, so this is something that apparently ALIMA got like a couple of engineers and a couple of doctors who were working in the West African outbreak. So they used like the difficulties and challenges that they found during that time, and they were designing this. This is not the same, but this gets from, you know, in UK, the treatment center that they had in
Carytown?
No, in UK, in London.
Oh, yeah.
So it was a quite similar system, which is like one room. Well, it's not exactly like this, but it was just like something like this. But imagine that there is a bed inside of that cube. That is what the treatment center in Royal College in London was, like a treatment center for Ebola cases. The 2 or 3 cases that they had in London, they were managing like that. So they realized that they were able to manage one patient being outside just using the gloves inside, and then they didn't have to wear the PPE all the time. So they used that idea combined to the idea of how can we do to have one place that we can give intensive care and we can monitor the patient directly and see the patient directly, and also get like different accesses to the tent. So then you can have people in PPE, but also people from outside that could be seeing what is going on, etc. So it's a work of ALIMA.
It looks very much like a burn unit setup. I wonder if they modified, some company making this and modifying the burn unit. I'm just interested in the supply chain. How do you get these things to the places they need to be quickly and
I think that it was constructed just for ALIMA, but I think my conversations with the people from ALIMA is that I think that they would be open to share part of the model to other systems as long as they are implemented in this setting. Maybe because ALIMA cannot expand anymore. What they are doing in Beni is already. So I was talking to them about like if we are able to find any partner who wants to come, or even WHO now that is partnering with the Ministry of Health to do it, would it be possible to get more cubes? And they said yes.
And they haven't been attacked. ALIMA hasn't been attacked.
ALIMA has been attacked, not so much as MSF.
Yeah.
And this is when the conversation becomes delicate. Yeah. Because it's just like the attacks to MSF was because of the war, or is because of the community was not trusting MSF.
Yeah.
Because, for example, when I was...
Well, they were there during the beginning of the war in 1994.
Yeah, no, they have been there for a long time. But, for example, here in ALIMA, we used to, every Sunday, we used to have like a group from the community, from religious leaders, traditional healers, like community, matriarchal communities and the secret societies and everything visiting the place, which is quite gross. But anyway, it worked. Which is like people come, just walk in, they see, so it's like a tour. Okay, you come to spend the day in a treatment center, so then they explain all the people in the community what was going on, so they were seeing the things and everything, and they didn't get like a direct attack. They were attacked a couple of times, but not in the same way as MSF. So many people were also talking about like if the attacks were related to the mistrust of the community, like in terms of the community doesn't know too much what is going on inside of that treatment center. They see just people coming and going, and people just coming very sick and leaving the place, being already dead. And so there's I think a component of mistrust from the community, the society.
You had another question?
Yeah, a few weeks ago, the WHO thought that the virus was mostly contained and that it could be stopped fully by September. But back then it was 25 cases per week, and now it's 75. What would be the reason for that totally failure of projection of growth, and what way could we avoid that in the future?
I think that DRC is a very complicated place to use, just like the normal calculation structures, because we are talking about like areas where people move very fast as soon as there is one attack. So, for example, when I was there, like the hottest spots where the rebels were attacking more at night. So you have one area that they have more cases of Ebola, and then tomorrow you go back and nobody's there. Because they have been burned out or they have been attacked and gunshots at night and everything. So these cases are already infected, so they end up going to another place. And just like, so there were like you know that in December they had the new elections? And then around February is when many of the attacks, like between January and February, the attacks increased. So they lost like a lot of contact tracing. Many people just went away. Many people were not able to be vaccinated. They are moving really fast, and they don't trust in the system, as I said before. So now we are seeing, in my opinion, I am not using any reflection of any of the experts who are on the field, but according to my experience, I think that after the election and the different attacks that happened after the election, I think that it's completely reasonable that now we see like a flare in cases. Because all of these are the consequences of contacts that disappeared. But it's because of the insecurity in the community, you know? And this is Ebola is already quite complicated, and you put it in this context. I can give an example. For example, I woke up. We used to have meetings like every morning to discuss about like the response and everything, all the different teams, like the vaccination team, the security team, the clinical team, and everything at 7 in the morning before I started working. You don't know what is going to be your day. You have your walkie-talkie, and that's when you get the instructions. No, like I got like a call at night saying that there are 2 new cases in Butembo, so I have to travel from Beni to Butembo to see those 2 cases, just to make sure that the new therapies are done, the intensive care is done, the monitoring, etc. And then when I'm going to leave, then suddenly somebody has put a bomb in the middle of the road, so I have to turn back and go back to my headquarters. And this is the normal thing, but this is for groups like us that we have like a big team of security. So then I don't say that it's safe because it's not safe, but at least you have like, we used to have like a lot of people, observants in the road, so the moment that they see any kind of a strange move or whatever, any attack that is coming, they can tell us in advance, so then we stop the response. But what happens in villages or for the general people? They don't have that capacity, no? So any kind of measure that we were doing is just conditioned by the security status of the country at that moment. And many things are just completely blocked. I remember being 2 days without being able to move from my hotel or my house or whatever, because there were attacks everywhere. So those 2 days, you are losing already 50 contacts that go to another place and then get in contact with others and others and others. So making projections, I think, in this context is very tricky. You cannot take them. How do we sort this out? I don't know. What do you think, Paul? I don't have a. I think that unless we sort out the civilian conflict, we are not going to be able to do much.
No, this is a very sobering, sobering update just from 3 weeks ago, and I don't know. I did want to ask a related question, the question of community mistrust and the historical trajectory that you didn't detail it, but you know it, that this is a sequela of the Rwanda genocide in '94. It's never really lit up that much. So, what you're, just to share, and I think, Ishan, you were going to say something too, but if you look at the case fatality right at the beginning of West Africa and the end, 70%. In fact, in the WHO piece, it's gone up 1%. So, I know your hypotheses, and we share them about why that happened, and so here's a hypothetical and related to the mistrust question, directly or indirectly. So with those interventions that were dismissed in West Africa, which you're calling, supportive and even critical care, case fatality didn't go down. You get it down to 36%. So so you have, just say this was on a larger, so that means less dead people coming out and more living people coming out.
More people vaccinated.
More people vaccinated.
So also,
but I'm
probably
thinking
the
about the
inoculars
mistrust.
that they get infected with is less.
Yeah. But I'm also thinking about the mistrust idea. You said it was gross, and I think to run people, I think you were saying it was gross to run people through the ETU like it's a zoo, but it's not as gross as being attacked, right?
No. I completely agree. But for me, the first time is like, what is all these people doing here? It's like, oh, we have the Sunday tour of the Children's Center. I was like, what is this? This is crazy.
So, I mean, this is hypothetical, but, a lot of what we saw in West Africa, the mistrust was not really directed to the clinicians.
No.
I mean, you never got attacked. We never got attacked, right?
No.
It was the burial teams. It was and the case contact folks and those.
It was the quarantines.
The quarantines. No food inside the quarantines, etc.
Very reasonable things, to be honest.
I gotta say, I mean, Jean and Byler and Siba, who's here, drew blood from a whole village and never had any trouble, right? Because they were associated with having put in place, treatment. So this is a long-winded question. I know that shocks you. If one were able to drive down mortality, and we know we can, using the very tools that were disparaged and even scoffed at during the West African epidemic, right? And so, say you go to 10%.
Yeah.
And you're using vaccination. Will the community mistrust and attacks just go on the same if it's regarded as a place where you're going to survive if you go in? Is it that partisan political, or is there...
No, I completely agree with you. I think it's a work that needs to be done more directly with the community about explaining what is going on, explaining all the situation, also to make them understand about the reduction of the mortality and everything. I think one thing that for me was very complicated in the interaction that I had with several of the communities, I went with the vaccination program to some of the villages many days and the surveillance. If I didn't have any new case, I just used to go with a couple of colleagues just to do vaccinations or sensitizations. People who were educated and they had the bravery to come into the partners just to confront you and everything else. Like, what are you doing here? And why did you come? And many of them came with the same thing. It's like, that we have been dying for the last 16 years and nobody has given anything to come here to help us. But now Ebola is here and all of you are here. Like when Ebola was not here, we could not see any white person around. And now suddenly, everybody's coming, with your fancy cars, with your new treatment centers and this and that. And it's a concern that I think is completely fair.
Okay, now the corollary question. So what about linking this to primary care or secondary care like you're doing in Congo?
Exactly.
I mean, that was the real question.
But you know what happens? The thing is that we need to work hard for that advocacy, and mainly now that we are realizing that listen, this is not going to improve in a short term. And this could be like a lesson learned from the West African outbreak, that it's not only about Ebola, it's about strengthening all the healthcare system. It's not only that. But the problem is that many of the donors of Ebola money only want to invest in Ebola, and they don't want that money to go to other places. So how do we manage now to canalize this money, apart from doing these amazing cubes and intensive care? Because it's the question that we were saying before about, like, you bring a dialysis machine for Ebola patients, but the patient who is coming to the hospital with the tubular necrosis is not able to get any dialysis because there was not even an ICU available, no? And you can put like a perfusion of adrenaline or dopamine inside of the cube, but somebody doesn't have a KEP reaction to be given for a normal bacterial infection, no? So how can we use now this money? And I think that the opportunity that we have, like the tricky moment we have right now, that we are very alone, but a lot of money will come because everybody's scared about Ebola. And Ebola to extend to Rwanda or to Uganda or to the neighboring countries, no? Or South Sudan, which is one of the big concerns that we have right now. Like using this money to just like strengthen and everything, because it's not only Ebola, it's this happens here because there is this problem. The conflict zone, but also the healthcare system is completely destroyed. So, yeah.
So if you know, the fear is this high, why not push for universal vaccination?
They cannot force people. So right now,
not offering it.
Yeah, no. Right now, if you want to get the vaccine, it's definitely free for you.
No, but I mean, it's just
Big
a ring.
campaign.
It's just a contest,
Yeah. Do they have it now?
No. They are given to what the mandatory thing, or what? Not mandatory, but the campaign is focused on the contacts, but it's open to everyone right now. So if you want to get vaccinated, you can go and in the places where the sets are for vaccination, they can get it. I think I agree with you. Like maybe let's change the speech and the conversation and say like we're going to vaccinate everyone. But right now, if you want to get vaccinated, you can get vaccinated, no problem. And they are vaccinating people who are not contacts anyway. But I think it was my impression, and I need to check this, but one of the big things is about like the quantities that they had in the beginning. No? Because I remember when I went in October, I was the one who was bringing the new supplies of vaccines because they had already run out of them in October. And the outbreak started in July.
So do we know if the companies that make them are scaling up production?
I think so.
I want to follow up on Paul's question. This is a little bit pushy, but I wonder if you, by virtue of your expertise and experience on the ground, in collaboration with the Minister of Health, could actually say to the funders, we won't accept your money unless it can be used for Ebola now as part of a scale-up for the larger community. Because you have some very strong and I think justifiable moral convictions about the necessity for what it takes to treat disease, not just Ebola, in these countries, that they could be part of the solution. I know nobody wants to turn away free money, but I don't see why strings can't be attached to it. And would they have other alternatives for funding that would be threatened, or could you actually push back?
No, I think it's a very good point, and I think it's something that I don't know if they have done it.
Well, we tried in West Africa and failed.
Yeah. Right,
the pushback, but you know, it's just, I think this is the spirit of your question and Megan's and mine too, is this grim report calls for a response. And what is that? Maybe more widespread call for vaccination and an insistence that the donors who are influenced by the WHO, the money has come to the WHO, commit to more integrated primary care. You know, and you know, that would be unprecedented and wouldn't be expensive. I mean, they made all these pledges that they never kept anyway, and that's why I was asking. You know, inside the if I just to add one thing, and then expect you to solve all the problems of the world. So it's clearly
I
you're
will sort them out, all of them.
Superwoman with ice pack. Now, you know, having been through that with you and Gene and many others, not the ice packs, the the very people who were saying you don't need anything other than ORS, you don't need to worry about renal failure, you don't need to use fluid resuscitation. I mean, you know who they were, and it was public, and it was in, and I mean, like in print, everything. But this experience is very different to your experience that you described. So, since the people who were saying the standard of care is the same for everybody as ORS, have seen some of this and have been involved until recently, the WHO too, right? Maybe that's part of the pushback, is to say, yeah, we could do a lot better, but you have to change the funding structure.
Yeah.
And that's where, I mean, the resentment that you described from the locals, hey, you just showed up, it would be palliated by more resources that weren't vertical, and we have this new tool that wasn't there until the end of the West Africa, and, well, let me just put it crudely, the people who were, making up crap about clinical medicine, like you don't need it, they seem a little less silent now, whereas you get to say, here's how you provide critical and supportive care. So that's three radically different things. Non-vertical funding, amped up vaccination, and insistence on proper clinical management inside. That was pillar one now, remember?
Yeah.
So it was pillar 0 in 2014. It was all containment. Put them in a stadium. So...
And also the image that you give as partners or stakeholders coming to work will change completely for the population. Like, these people came, they came for Ebola, but look, they are strengthening the healthcare system, they're doing something for us, because I think that they have a point, a very clear and very fair point about, you really don't care about us.
Yeah.
You are coming here to do your thing. You do your thing and you go.
Which is kind of the stadium thing, if it's containment.
Exactly.
Because in the current outbreak, the case fatality rate is back to 70, right? 1,696, meaning the one that, so, I mean, maybe this is something, if you're making an appeal in this room, maybe this is something we should fight harder for, getting the messages right, 1, 2, 3, as a sort of pushback to support, the poor folks at ALIMA, the Ministry of Health, and the WHO, God bless them.
Yeah, no. And also, because right now the situation is that all the good progress that has been done after the experience in West Africa, all these lessons learned that I was explaining to all of you and everything, they are just about to get lost, or because of mistrust of the communities. When people say about everybody's really concerned about it's the war, and it's well, most of the people who were working there when the attacks happened don't have a very clear idea that these were the Mai rebels. We really don't know who were the ones who were attacking.
Yeah.
It's very easy to say it's a war zone and that's why it's attacked. It's it's not very clear. I was talking to people who were there, and it's most of the people didn't really identify themselves as the attackers. So it's if it was really the Mai, they would come with a statement saying that we are the ones who are the authors of this, but they didn't. So it could be the community for mistrust, could be a neighbor who is not happy with the death of his mother, could be many different areas, So it's exactly what you say.
Yeah, we had one in Sierra Leone. It was kids because they built the unit on their soccer field.
How would you, if you were working in a rural area or any area really, how would you keep your finger on the pulse of community, what's going on in the community, in a super effective way? So if you were going to hire people, an anthropologist, somebody who's fluent in the local language and customs, who was really there to tell you, okay, here's how the community feels right now. Here are the complexities in this particular site. Is that something that would work in this situation?
Yeah, no. There's a lot of community sensitization and programs involving leaders from the communities and just trying to get people engaged. But
I almost mean the other way around, where the staffers, it's people who are sensitized to what the community's thinking, as opposed to just, informing the community what's going to happen.
Yeah, I think and I know that many of the sensitization campaigns are done with people who are from the community themselves, So it's not like external people come in to give, but it's more, I think we tend to make this mistake a lot, like sending people just to give speeches and with the microphones and all these things, and it's more about like, and I think Congo is changing a little bit, at least my impression when I was there in October, November, is that they are starting to do more things about like sitting down in a community about like, how are we going to approach this? So the chiefs of the communities are deciding how they want to do their isolations in the community, how they want to manage the burials, how they want to do this and that. So it's the community itself that are just making all decisions, and then they go to the ministry and they report like, this is what we want. This is how we want it. No? But yeah, but it's still like, the attacks are still ongoing. So many, the structures that we have of community, villages, is not so rigid as in other areas, because people move a lot. Like many communities just get attacked at night and then that community disappears. So all the work that you have been doing in that area is starting again, because now everyone is just completely dispersed in the country.
I mean, I think that's a strong argument for amping up vaccination and away from ring vaccination. If they disappear and they've fled into the bush, right, and some secret garden or something, they're hiding somewhere, and I mean, it's just like, see, how could you do ring vaccination at all? But, well, I have to say, this is the best talk on Ebola I've ever heard, and I've heard a lot, and I mean, this, watching your face light up when you're talking about the cubes in the middle of that, I mean,
I love the cubes.
I know you love the cubes. I know, it's beautiful, and so are you, and thank you for what you're doing now, what you've done in the Congo, and I think we should give Marta a big round of applause. Oh boy.
Okay.